So we're going to be talking about fat grafting. It's a very vast topic when you talk about aesthetic surgery, and it's a multi-facet graft. So before, basic things. You know, we've got two fat compartments on the face. One is a superficial fat compartment, one is a deep fat compartment. Most of the loss that we see on the face is because of the superficial fat compartment, the fat from there being lost. So when we talk about fat grafting, it is this compartment that we actually want to give back volume and give back structure. The deep fat pads are usually not affected by the aging process. Only thing that collapses down inwards, but we don't give back volume to the deep fat pad. We already spoke about the ligaments. This is what it looks like, and these are the three ligaments that actually matter quite a bit to us while the collapsing and the aging process happens. Now, what is fat and where do we primarily use it? We use it for a lot of different purposes. We use it for cosmetic reasons, we use it for congenital defects, we use it for secondary deformities. The main aim behind this is you should have the ability to harvest good amount of fat. The kind of cannulas that I use to harvest the fat is in my kitty. I have 3.4, I have a 2.4, I have a 1.5, I have a 1.2. And then I have the filters next to it that help me titrate the fat and make macro. I usually use for secondary deformities, otherwise I don't use it, become very clumpy. Most of the fat that I use for cosmetic purposes and deformities is going to be micro and some amount of nano for skin texture. Some people like to centrifugate fat. I don't. I leave it to settle and then I use the filters. And the settling time is about 10 minutes. This is the fat grafting set, but Dr. Arun will be talking about the fat grafting set after this and a few more things. Are there some contraindications? Yes, there are some contraindications to fat grafting as well. Patients who are immunosuppressed, history of keloids, recent history of radiation, metabolic diseases, and excessive burn scarring. You won't get much results in burn patients if you think that fat will help in such patients. Whenever you put in fat, two basic concepts that come into play is two types of forces, which is compressional forces and torsional forces. Just like you expect about 30-35% of the fat to resorb. Yes, it's absolutely true. That is why you will overfill the defect, or even for a cosmetic purpose, you're actually going to do a little more because you can't take the patient back again and again to give back volume. So two types of forces, torsional and compression. What are these forces? You fill fat on the face. What is the patient going to do? Patient is going to go back, follow the normal routine, massage the face, rub it, and then they're going to sleep on one side. So it's going to get compressed. So there are two types of forces always acting on the face when you inject fat, which is torsional, rotational, or compression forces. So that helps the fat resorb faster. And what is the layer that actually resorbs? Once you graft the fat one on top of the other to get a deformity up to the normal limit or a little more, what is the level of the fat that resorbs? It is the fat which actually doesn't neovascularize. The other amount of fat which vascularizes and becomes flush with the tissues there is the fat molecule that actually survives. Every other kind of fat which actually is on the top surface, which does not get the vascularity, it shrinks, it atrophies and goes off. So that is the 30-35% of the loss that we are expecting. So plane of injections, I'm not going to be talking too much. Buccal fat we've already seen.
No, you need to talk about the planes of injection.
Okay.
Because that is what we have to learn. No, inject here.
We'll show you the video.
Alright.
We've got a lot of videos here.
Okay.
Buccal fat, Dr. Arun has already taken, so we don't have to talk about it, but the results are very good, and these are the kind of patients that you actually want to do a buccal fat reduction. Can you see a subtle change on the face? This is what the buccal fat reduction actually does. So we were talking about chin implants and malar implants. We spoke about these are called peak implants, but see how the fat actually augments the face. Apart from just putting the implants, which can be, I primarily use more of facial implants, which are peak in nature for the chin, for the mid face, but on top of that I will always augment with microfat. And this kind of mid face enhancement is something that will stay with the patient. It is a lasting effect, and fat is actually autologous and it has adipose derived stem cells. So can you imagine the kind of rejuvenation it will give to the tissue? So that's the microfat that I'm injecting with a 1.4 mm cannula, injecting cannula, 10 10 centimeters in length. There are various techniques. These are basically in the subacute plane, and after placing my implants, I will go in and place my fat that actually rejuvenates. Defects like these are something that you can fill. Cleft deformity, after doing the scar revision, we were able to do a lipofilling for the perioral structures. Now, what are the commonest sites for harvesting fat? Now this is a 2.8 cannula which I'm using for harvesting. After I've put in tumors into my abdomen, you can either use a belly approach, basically 6 centimeters below your belt line can be an access point, or the lateral wings can be an access point. These are the commonest sites that you can access. You can even use your inner thighs, but I choose the abdomen more often. Why do you see so much of RBCs coming in my fat rather than natural fat here? Anything that you can actually put across? Can you come to know? Why do I have so much of RBC content in my filter, in my syringe? This patient had a history of a bypass twice. We could not add adrenaline in our tumescent. That is why. What is the composition of tumescent? Arun sir? Arun, come. Chocolates भी खत्म हो गई. अब पानी की bottle देना पड़ेगा. चलो, what is the composition of tumescent? Lignocaine, adrenaline, what else? Saline. If you want lasting tumescent result, what can you add to your tumescent? Bupivacaine. You can add bupivacaine to your tumors also. It gives a lasting effect. But yeah, what you mentioned is absolutely right. Ajo. Anything else about the fat you want to ask till now? So, these are all microfat that you can actually combine in your routine practice. This patient got a rhinoplasty done with us previously, but she had a dimpling there, and her main problem was face was looking very dull and malnourished. So, with not just combining fat for the nose, but how many of us think that the submental fat that we harvest can be used on the face? We think we can use it? And how much fat are you expecting to get from the submental area, ideally? Very little. If I may ask, how many ml are you looking at? 4-5 ml. And how much do you want for a full face rejuvenation if you're talking about fat? Even if you're when I augment the full face, an ideal measurement of fat that I use is about 30 ml of fat. 30 to 35 ml, and that is filtrated fat. So that means your total amount of fat which you harvested would have been at least 100 ml. So you can't, the submental fat is very loose fat. You ideally can't use it. You think we can use submental fat for facial augmentation? These are kind of results that you can get. This is another one. So basically what happens is there's a complete facial rejuvenation. This patient obviously underwent a rhinoplasty, mid-facial rejuvenation, and microfat grafting as well. This is the belt line incision that I'm talking about. If you can see, a small incision 6 centimeters below the navel, and the first thing is you ideally, what is the settling time after you put in your tumescent? At least, right? No, we should ideally leave it for about 8 to 10 minutes, and it will help you emulsify the fat in a better manner. And after that, you can obviously use your negative pressure. You can use a suction cannula, you can use a motorized suction and to harvest the fat. It also depends on the amount of fat that you're looking at. And if you can see, the first quality of the first kind of fat that you get will be full of a little bit of tumescent and mixed fat. It will be the second lot of fat which will be pure fat, which you will start getting. And that is the good fat that you actually want to use for facial grafting.
Atri, can you explain the plane, please?
This is all subcutaneous.
Yes.
This is all subcutaneous because, and most of it, if you see the direction of the harvesting, it is all pointing subcute and upwards. You will be able to feel the other end of your cannula at any given point of time. At no point of time will your cannula be pointing towards the viscera or the muscles down below, right? And it is all tactile here. It is all tactile. If you're too superficial, you'll come to know. If you're too deep, you will not come to know where the cannula is. So, and that is the ideal depth where you want to actually access the fat. This is how you isolate. And once you isolate the fat, you will have some amount of RBCs there, and the ideal settling time there is, okay, you'll have to turn your heads. Okay, is about 10 minutes. From
One
here,
second. Are we clear with the way of the method of harvesting?
it's clear, right? There is no major thing here. It's basically tactile, it's basic science.
So you place the stab incision first?
Stab incision, normal 11 number stab incision, but that they've already seen.
अभी और आएगा मेरे?
हाँ, एक और है. So you use your filters. These filters basically are used to make your fat. This is a 1.4 mm filter which you will basically use to make micro fat. If it's a 1.2 and lesser filter, you will be making nano fat. And then your injection techniques remain the same pan facial region. For under eyes, mid face, temples, if you can see the cannula and the widths will start changing. If you're using under eye, like in this case, we're using for rejuvenation, so we are using nano fat actually. So, okay. Yeah.
When you're injecting, are you creating a tunnel first, or are you?
So these are all entry points that we create, ma'am. If this is a cannula which I'm using, so I will create I use an 18 gauge needle to make my entry points while I'm injecting. On the face, I don't do any stab incisions to create my entry points because 18 gauge needle is more than enough for the cannula to make your entry, right? But while you're harvesting, you will have to make a small stab incision into the subacute plane. And that's all you need for the entry to harvest your fat. And that's the only time I actually make a puncture wound. Otherwise, all the puncture wounds are with an 18G needle.
Can you explain about the needles, the harvesting needles? Can you use different sizes?
Yes. So, Achal, he's wanting to show, he's made some of his own, so he will show you that. But basically the filters can keep changing. Either you can have a complex set which will have 5 cannulas to harvest, 4 to inject, or keep it very simple. Your basic macro fat comes in 3.5 mm cannula, or you can bring it down to 2.4. Micro fat, ideally 1.5 is more than enough. Anything below 1.2 will become nano fat.
And near the orbit, we normally use a nano.
It depends. If it's just for rejuvenation, then the nano. If it's for volumization, then the micro. Macro we only use for secondary deformities. It's clumpy. It's lumpy and clumpy, so it will be irregular. So only for secondary deformities you will want, and that too you can layer. You can put a lot of macro fat and some amount of micro or nano fat on top of it. Nano doesn't stay. It's the micro which will stay and give the smooth skin on top of it.
Sir, why you don't centrifuge rather than filter?
Because if you read the study regarding it, if you filter or centrifugate fat, you're actually losing adipose derived stem cells. So the more you centrifugate, you're creating heat, and that kills the autologous stem cells in the fat. So it's better to let it settle. So same way, injecting technique remains the same. I'm using a long cannula for the temples. If you want to see these videos, I can show it to you. Otherwise, these are regular injection technique. Sure? Okay. This is microfat. So what we basically do is, you use a long end cannula, because I told you the temples and the midface are very important. So giving back volume, see the amount of, I'm giving 10 ml into the temples. Just 10 ml into the temples, about 10 ml to the midface, and if I want to do a jawline, then 10 each. So how much does that become? That becomes almost 30-35 ml per side sometimes. So that much is needed. You are overfilling, but it is essential, and most of these you can see on table as well.
So this is done under
This is GM. So this was an autoimmune case of morphia, if you see. In this case, my judgment was wrong. What I did was, morphia is an autoimmune condition, so it's continuously going to, there's not going to be any subacute tissue there. So a lot of subcision with a wedge cannula, but what I did was, I put up microfat there, a lot of it. I put up almost 50 ml of microfat there. And this was the result after putting in 50 ml of microfat there. In 2 weeks time. This completely went off. So I had to redo the procedure, and in about 6 months time we did it again, and it's been 1.5 years now. He's doing very well. We put macro fat. So basically the tissue tension was so much that it actually compressed the micro fat and gave way. But in cases like this I will actually treat unlike a cosmetic thing, I'll treat it more like a deformity. It is a deformity. So the macro fat held in place has been 1.5 years plus now. It's going to be 2 years now. and he's still the same, he comes for a follow-up once every 6 months. So cases like these are where you will use macro fat. And it doesn't look too clumpy. Does it look clumpy? It's just that you need to assimilate the fat in a manner. You put good amount of macro fat, and on top of that you put some amount of micro fat there. So it gives the smoothness and the evenness there. Again, this one was just for a rejuvenation. If you see, he complained of a tired looking face. So complete facial rejuvenation with complete face fat grafting. In 4 weeks time, there's kind of a glow that comes onto the face. It's primarily the adipose derived stem cells that actually show the results, give the nourishment to the skin, and looks better. So deformities like these, we use a lot of combination for, can you see this? She had his encore resection done, maxillectomy done on the right side, came in for a lot of things, ectropy and ophthalmos, defect on the right side, incompetent lips, so we put in that PSI, did a canthopexy, cartilage placement, corrected the ophthalmos, and all the fat grafting actually made the difference. This is all macro fat. Can you see the volume there? This is all macro fat, and nothing else will stay. So cases like these, deformities like these, macro fat is the way forward. So, and you see her face. It's just that there's some edema. This is just 1 week post-op. That will also go off, but it makes a difference. So if it's deformities and you're talking about say cases like these, macro fat is the way forward with some amount of combination of micro and some nano. You can use it for acne scars or tissues which are irregular like this, but in this you will use more of nano fat to give the smoothness, but you will have to use a wedge-shaped cannula. Are you showing the wedge cannula also?
We need to finish.
Okay? Acne scars and GG, okay? Okay, come.